All right, good morning. It is 7 o'clock. We have today Dr. Mailo. Thank you for coming to speak. And you can go ahead and proceed. Thank you. I think you are muted though. There you go.
Yeah. Good morning. Thank you. Thank you for having me. My name is Janette Mailo. I'm one of the new hires in the Division of Pediatric Neurology. I'll talk today about our new consensus guidelines on pediatric intracerebral hemorrhage. This was an multi-center international effort that took quite a bit. It took 5 years to put together. And the reason for this was kind of to have something for the practitioner who work with children who is the pediatric intracerebral hemorrhage, and just to have some sort of a guideline, something that would guide the management, the decision making. So this is based on consensus statements. So we were about 20 of us, and with different specialties. So pediatric neurosurgeons, radiologists, interventional radiologists, pediatric neurologists, intensivists, and we were trying to get a consensus in certain areas, and in certain areas we didn't get consensus, and I'll talk about that as well. But at the end, we have some sort of a guideline, some sort of a framework to help children with intracerebral hemorrhage, kind of to have the best outcome. There is still a lot not known in this area. So my objectives today is I'm so sorry, I forgot to mention I have a loaner laptop because my laptop's still working. It makes funny sounds. I think it's the fan, and also the sound is softer. So if you cannot hear me and I cannot see the chat, please just say that I have to speak louder. We just noticed that. So I'll talk first a little bit about the pediatric intracerebral hemorrhage, and I'll compare the term with hemorrhagic stroke, which is not the same thing, and it can get very confusing. I'll talk about epidemiology. I'll talk also about pathophysiology and etiology of pediatric intracerebral hemorrhage. I'll talk about about the areas where we reached consensus. So kind of what are the areas that we feel like this should be kind of a standard of care. Standard of care, I also mean it should be within the clinical judgment as well. And I'll talk about it as well. I'll talk about acute management. So when the child first presents, and a long-term care just to ensure the best outcome for these children. So first I'll talk about introduction and epidemiology. So first I'll mention pediatric hemorrhagic stroke is essentially stroke that leads to the bleed in the brain. So it's compared to pediatric intracerebral hemorrhage, which is the most common form of pediatric hemorrhagic stroke, but it's not a synonym. So intracerebral hemorrhage is intracerebral, so it's a parenchymal hemorrhage, or is the hemorrhage in the ventricle. Also, non-traumatic subarachnoid hemorrhage would be actually part of this. Hemorrhagic stroke also encompasses subdural hemorrhages and cerebral venous sinus thrombosis that can lead to ischemic hemorrhage. So that would be the hemorrhagic stroke, while the intracerebral hemorrhage is purely non-traumatic, so spontaneous hemorrhage in the parenchyma or in the ventricles. So I hope it made sense. If not, I'm happy to explain it again. So the annual incidence is the incidence, it varies in the literature, is anywhere between 1 to 2, some literature 1 to 3 per 100,000 children per year. So it's about 50% of all pediatric stroke. So this is very different compared to adults. Kids bleed much more often than adults. In adults, most of the strokes are ischemic with about 20% hemorrhagic. Why it is important? Because it's relatively rare. 1 to 2 per 100,000 is not very common. However, these kids have a high morbidity, also mortality. The mortality is lower compared to adults, but the morbidity is significant, and these kids live with decades of life with challenges. A lot can be done if hemorrhagic stroke or intracerebral hemorrhage, if the bleed is recognized early, and the child has that specialized management that can help, that can improve the outcome. So, as I said, pediatric intracerebral hemorrhage refers to non-traumatic hemorrhage in the brain parenchyma of ventricles, and it's a pediatric. It means over the age of 28 days. So we are not talking about neonatal hemorrhage up to 18 years of age. And the reason we are not including the neonates, because neonates tend to have different pathophysiology of bleeds, which is there is a different management for neonates. So neonates are really not little kids. Neonates are neonates, and the approach is a bit different. So hope it makes sense, the difference between intracerebral hemorrhage versus hemorrhagic stroke. Hemorrhagic stroke is just a bigger umbrella. Intracerebral hemorrhage is part of it. The most common reason is some type of vascular malformation. Those are the most common reason for bleed, and those that are working with inpatient and with children, either on the wards in ICU, we do see this, and we do see a couple a year, definitely. Intraventricular hemorrhage is the blood within the ventricular system, and it could be either the primary ventricular hemorrhage or it is a secondary extension from the intracerebral hemorrhage. Typically, intraventricular hemorrhage is associated with worse prognosis and often leads to hydrocephalus that has to be managed separately from the hemorrhage. Subarachnoid hemorrhage, this is meant to be non-traumatic subarachnoid hemorrhage, so something like aneurysm hemorrhage, and it is the bleeding between subarachnoid space, and most common is the ruptured aneurysm. It's interesting that the incidence of pediatric intracerebral hemorrhage has this bimodal distribution. So the incidence is higher in infants under the age of 3 years. And then the incidence tends to be lower in early childhood and then peaks again in adolescence. So the literature varies between 12 to 15, 12 to 18 years. And again, like there are different causes that need specialized investigations, and I'll talk about them a little bit more as we go. In terms of pathophysiology and etiology, the most common in pediatric world are the vascular malformation, so structural abnormalities. Also hematologic and coagulopathy, as well as pediatric tumors. This is very different from adults. In adults, the most common reason for brain bleed is hypertension and amyloid angiopathy, which we don't see in children. And this is very important because while in ischemic stroke, we did extrapolate from adults when we prepared the stroke protocols and kind of the care of a child acutely and hyperacutely, and even long term. When in a child with ischemic stroke, as I said, we extrapolated quite a bit from our adult colleagues. We cannot really do it in hemorrhagic strokes just because the etiology and the pathophysiology is so different. So as I mentioned, structural vascular abnormalities are the most common, and this is very important to recognize because that's where our acute management will be focused. The most common out of the vascular abnormalities, the most common would be AVM or arteriovenous malformation. Less common, but still relatively common in this group would be cavernomas, arteriovenous fistulas, and aneurysm. And that's very important to realize because very often our early imaging needs to be followed by detailed vascular imaging to identify these lesions. And then our neurosurgical colleague will decide if and when is the best time to perhaps surgically intervene. Coagulopathy and brain tumors are also in that group, but much less common. So the most common out of the vascular malformation that lead to pediatric intracerebral hemorrhage are arteriovenous malformation. It's about half of the cases. So it happens. It's common. We actually have one right now in in our ICU. It's interesting that although these are thought to be congenital, those are developmental anomalies that are thought to be there essentially since birth, only minority will become symptomatic in early age. The risk of rupture is 2 to 4%, so it's definitely the risk is there. And it is as I said, it is the most common reason for intracerebral bleeding, for the brain bleeding kids. And what it is essentially it's abnormal connection between the arteries and vessels without the intervening capillaries. So those are the high pressure, high flow lesions that are prone to rupture. This unusually child that presents with ruptured arteriovenous malformation, they tend to be very sick and need a multidisciplinary approach. So this is just the illustration what it looks. So digital subtraction angiography would show this nidus, which is that kind of that entangled abnormal vessels with large arteries that are feeding either high flow and high pressures, the veins, again, without that intervening capillaries, so slowing down the blood flow. So there is no the normal capillary bed. And on the MRI, very often we can see the nidus, some hemosiderin deposition if there was a previous bleed, and the parenchyma looks quite abnormal. So they have a very typical appearance, especially the bigger ones on the imaging. Another type of vascular malformation that we can see in children that present with intraparenchymal hemorrhage is arteriovenous fistula. These are also abnormal connection within between the arteries and veins, but they don't have don't have that nidus, where is that those entangled vessels. Instead, it is just feeder, typically one artery that feeds either cortical or dural vein. It's just kind of just the one feeder. It looks a little bit different on the imaging, and there is not that kind of a mass of vessels, and that distinguishes it from anteriovenous malformation. Very distinct appearance. The least common, but still happens, is the cavernous malformation, and they have what we call popcorn sign. So it's kind of that like a bubbly pattern with the hemosiderin ring, and we call the blooming artifact. So the blood within the area of the cavernoma. Sometimes we can see multiple cavernoma, which would increase suspicion for either familial cases, hemorrhagic hereditary telangiectasias, one of those also that we should consider if we see multiple cavernoma. Cerebral aneurysm are less common in children, and in children in general, if they have aneurysm, it's different than in adults. They have giant aneurysms, so they're much bigger, and very often there's a thrombosis of the vessel there, and they can also cause mass effects on the adjacent structures. The other type of aneurysm would be fusiform aneurysm, which is also common in pediatric population, but less common than common, like relatively common. It can be seen in pediatric population, but the giant aneurysm, the larger aneurysm are just more common. And this is what they look like on the imaging. And sometimes there is no vascular malformation. So in children that don't have vascular malformation, again, the most common reason for bleed, the next step would be to look for hematologic disorders. And very often that can be obvious from either personal history, past medical history, or family history. Usually the hints are there. So the hematologic disorders are another type of disorder. Of course, they need very different type of management and approach. The hemophilias, either A and B, are common, and they might require replacement therapy due to the factor deficiencies. Thrombocytopenia, they are very often acquired. So it can be either ITP, leukemia. Sometimes those are thrombocytopenia can be related to certain treatment that the children are undergoing. Sickle cell disease, that's another group of children that can present with brain bleed. Although ischemic strokes are more common in children, they can have hemorrhagic stroke as well. Vitamin K deficiency, sometimes we see it with nutritional deficiency, malabsorption. And in our world, very often these bleeds are related to treatment with anticoagulation. So our cardiac kids in the cardiac ICU, or even just the left ICU, those that are still on anticoagulants, whether it is warfarin or other anticoagulants, can also have a bleed, and it's always very difficult to management. The ideally is an immediate reversal. Sometimes it's not really that feasible, especially if the child is on a mechanical circulatory support. So this requires very different management and very careful weighing what's next, what is the higher risk if the child rebleeds or if they will have a ischemic stroke if we stop the medication. So that's a very different population where, as I said, the management can be very difficult. So now we know that the child bled. So what do we do? So, oh, now we have okay, sorry. Now we have a child that we expect a stroke, perhaps a bleeding stroke, the hemorrhagic stroke can be one of the differential diagnosis, top of the differential diagnosis. So what do we do? So anytime we expect some sort of a cerebral accident, whether it is ischemic or maybe there is a suspicion for bleeding stroke, the first thing is to perform imaging, just to confirm that. We did reach a consensus that either non-contra CT or MRI can be used. There was there was no really there was no really debate which one is better, which one is a better test. The issue is MRI in some centers, and I mean I was practicing in Canada for years, and we had the same problem as many centers, for example, in Europe have, that we didn't have MRI available every day after hours, and we didn't have anesthesia readily available. So for us, we would definitely do the CT head. So that's why our consensus was either MRI or CT are a very appropriate test as the first step to identify the pediatric intracerebral hemorrhage. And CT, the advantage of CT, often it doesn't require sedation in younger kids. It's quick. It can very quickly identify the bleed. However, MRI, if it is available, is a more detailed image, so it can give an idea of if there is a AVM, if there is a covered number. Just the picture is better. But as I said, in terms of the first line imaging, they're both equally good test. MRI, what is the advantage of the MRI? Besides the fact that there is no radiation, it can also point to some of the ischemic lesions that can be associated with bleed, which is also very important. Both will give us information about other complications that will affect the acute or hyperacute management. They both can identify edema, mass effect, midline shifts. So they're all both very useful. Um, once we do ideally with the first imaging, whether it is CT or MRI, if there is a thought of a stroke, ideally vascular imaging would be good to get done during that first imaging acquisition. Sometimes it's not done, but it definitely should be followed. Once the bleeding is identified on the CT or MRI, the vascular imaging should be the next step, just to have an idea what we are dealing with. Again, vascular imaging, because the vascular malformation is the most common reason of bleeding in children. It will be ideally done right away. The first step is to stabilize the child. So even the first imaging, even the initial imaging has to be weighed against the stability of the child. So the child that needs significant hemodynamic support, does significant respiratory support, might need a stabilization before the imaging, especially before the vascular imaging that takes a little longer. So again, even though yes, in the consensus is that imaging, including the vessel imaging, should be performed immediately, that has to be weighed. There's a clinical judgment against the stability of the child. Once the child is stable enough to stay in the scanner, and sometimes just simply the stability of the patient might dictate that the CT is done first because it takes shorter time. So the goal is to identify what is the cause of the bleed and ideally guide the treatment. As I said, high consensus was in disagreement. Just this has to be just a kind of a common sense. What about the next step imaging? Does everybody need digital subtraction angiography? Well, it is a gold standard, and again, it depends. Yes, it is a gold standard. It is essentially the imaging that will identify any structural abnormality with the best details and provide kind of the best guidance for for a neurosurgical colleague what to do next. Uh, it definitely should be done if we don't have anything definite on the non-invasive imaging, so CTA or MRI, or if simply those imaging cannot really define properly the lesion. However, again, it is the more invasive test. It needs sedation and also needs the child to be able to stay supine, which sometimes for a long time, which sometimes it's just not possible. Sometimes we need for the neuroprotective measures, we need a child to have a head tilted 30 degrees, which essentially would make a DSA unsafe in the very acute stage. So yes, it is a great test with superior resolution, especially for smaller AVM. We need to make sure that the child is stable for that. So again, benefits versus risk. There was a consensus to repeat imaging at 3 to 6 months, and the reason for that was sometimes just takes the time to define the lesion properly. Sometimes when there's lots of blood early on, it's really hard to tell and hard to identify the lesion. So the repeat imaging just to see where the state of the vessel is was considered to be the appropriate next step. When you have a big bleed, just not always is possible to identify the vascular malformation well. So this is just the picture of just a basic pathway. So when the child presents with suspected stroke, the first step, as I mentioned, would be to obtain brain imaging, whether it is CT or MRI, ideally with vascular imaging, depends on the center, depends on the state of the patient. If there is a vascular lesion seen, they might be need for DSA at some point, whenever it is clinically appropriate. Sometimes there is no vascular lesion seen right away. As I said, if there is a big bleed, very hard to see. But maybe other non-vascular lesion will be revealed. So then we have our answer. If there is no lesion revealed, as I said, we should consider digital subtraction imaging as soon as the child is stable to do so. This is kind of very similar, just like nicer, just nicer and easier to follow. And if there is no etiology identified, coagulopathy workup, even in the presence of negative family history, absence of personal history, that can be something that would be definitely the next step. So I'll talk a little bit more about the acute management, and I'll talk about the areas that had strong consensus. So again, just acute management, any other sick child that comes unwell, unstable, altered mental status, airway, breathing, circulation. So that's our colleagues in the emergency room, and our intensivist colleagues will take care of this part. Again, we might get involved once the brain imaging shows a bleed, and usually besides neurology, neurosurgery is also immediately consulted as well as hematology, just in case there is more we need more just one second, sorry. So neuroprotective management. So the part of the neuroprotective management is elevation of the head to 30 degrees, as I mentioned, which can preclude us from doing some of the further imaging, especially DSA in the acute state. And we typically follow strict normothermia, normoglycemia, and euvolemia, and continuous monitoring for signs and symptoms, especially of symptoms of increased intracranial pressure. A role of a neurology also is to help with the continuous EEG monitoring, at least for first 24 hours. Airway protection, there was a strong consensus to secure airways in children with decreased level of consciousness. And so GCS score less than 8 with respiratory instability or those that cannot protect their airwaves, so that should be considered for intubation. The ventilation goals should ensure adequate oxygenation, and what we need to avoid is hypoxia because it increases the risk of the ischemic stroke and also hypercarbia. And in terms of neuroprotection, again, the cerebral oxygenation should be maintained, ventilation, and also prevention of aspiration pneumonia, and also following the child with the continuous EEG to make sure that the child is not seizing, which can again negatively impact outcomes since it is a high metabolic seizures are a high metabolic demand state. If there is a coagulopathy that we can reverse, it should definitely be done. And it's very important it's done timely because if there is a coagulopathy, it can be reversed. Until we do that, we cannot really correct the bleeding. If there is something that we can do, for example, if the child was on warfarin, we can reverse that, add fresh frozen plasma or vitamin K. For some of the specific factor deficiency, for example, in children with known hemophilia or von Willebrand disease, we can just administer the appropriate factors. If the thrombocytopenia is an issue, again, platelet transfusion, it kind of depends again on the child's state and clinical situation. Another important step in management of these acutely sick children is the ICP monitoring. And there was a consensus that ICP monitoring should be considered for children that are very ill. It means that the GCS is less than 8. Clearly, those are children that needed acute management, including the ICP, or especially because we can really clinically assess for any signs of changing or worsening intracranial pressure. The target is less than 20 milligram, less than 20 millimeter. And the typical indication would be the herniation, the posterior fossa hemorrhage, especially because it can lead rapidly to hydrocephalus and also it can lead to brainstem compression. When to place it in, again, it depends when the child is clinically stable to even stable for this procedure, because again, it's a procedure. So again, our neurosurgical colleagues have to weigh in and as per their judgment, kind of weighted benefit versus risk, especially in a critically unstable child. The EVD is usually the most common method because it allows for not only monitoring of ICP, but it can be also the fluid can be taken out if needed. What do we do for increase the intracranial pressure? We either administer hypertonic saline or mannitol, and the doses are the typical protocols that guide the management. So mannitol typically 0.25 to 1 gram per kilo. It has a rapid onset, but we have to be very careful because of electrolyte disturbances, and it can also cause hypovolemia, which can be dangerous in critically ill children. Hypertonic saline is another option, and especially in hemodynamically unstable patients, it is the preferred agent. The idea is to create osmotic gradient and just to get the water out of the brain and decrease the cerebral edema, so minimize the swelling as much as possible, and prevent further damage in the brain. And typically we watch serum osmolality and especially avoid hyperosmolar state. Again, sometimes we allow slightly higher levels just if the edema is significantly increasing. There was also a strong consensus for urgent surgical evacuation for cerebellar, especially cerebellar hemorrhage. And again, this has to be weighed in with the patient's stability. The patients that have a respiratory distressed, the patient that is respiratory unstable, this might not be appropriate early on. So again, our neurosurgical colleagues, together with the intensivists, have to decide, even though the urgent surgical version is recommended, is it really at the best interest of a child that is unstable? Oh, especially if the hemorrhage is more than 3 centimeters, it tends to put lots of pressure on the brainstem, and the risk of herniation is fairly high. The children that have significant obstruction of the flow, so it can cause rapid hydrocephalus, compression of the brainstem, or significant clinical deterioration, should be considered, and this should be just discussed. Again, is a clinical judgment of the neurosurgeon when it's the appropriate to do that. Especially for cerebral hemorrhage, often the most appropriate intervention is the craniotomy, suboccipital craniotomy, so the posterior craniotomy. It can be with or without hematoma evacuation. Again, it depends on the state of the patient, how long the patient can even tolerate being flat. And EVD is typically put in so we can monitor the pressure. It does improve.
Well, we got a head ultrasound that day. I remember, yeah, it did.
It does improve mortality. Doesn't always improve morbidity, unfortunately. Again, just that multidisciplinary approach, a discussion between different specialties will guide this step. Another consensus was to start early rehabilitation as soon as the child is able to be rehabilitated. They don't even have to be necessarily awake for that. Physical therapy, so just to take care of the muscles, stiffening, contractures, tone management early on, even in the hospital before the transfer to rehabilitation facility, just to start with activities of daily living, motor skills, especially the communication. Some kids have impaired communication, which those will often have also swallowing dysfunction. So very important is to start communication as soon as the child can somehow participate. It also improves kind of the mental health outcome and decrease frustration, because the children that cannot communicate tend to have more, and I'll talk about the more mental health, more issues, those that are aware of not being able to communicate. The neuropsychological assessment, again, early on is recommended, but it depends on a child. The child needs to be awake, needs to be able to be assessed for neuropsychological assessment. But early assessment can be beneficial for the kind of acute management, and that's the management once the very early interventions are done, but still while the child is still in the hospital. So those were the areas, again, as I mentioned, I just summarized these areas of high consensus. So airway management, of course, especially in the children with GCS less than 8. So airway management by using the intubation, the consensus was high. If there is any coagulopathy, there was a consensus, definitely there should be a reversal of coagulation as long as it is safe. ICP monitoring, again, more so in children that have low GCS and impending herniation. Managing ICP with osmotic therapy, which will hopefully reduce the brain edema and improve the outcome. The surgery, especially for cerebral hemorrhage, again, if the child is safe to go for surgery, this would be greatly beneficial for improving mortality and early rehabilitation to maximize functional recovery, again, as long as it's safe. And I'll talk a little bit about areas that there was no consensus. And this is a very important one, because it always
Hey,
comes.
Janette, sorry, do you mind if I because I don't want to get too far past that before I
Yeah.
jump in and make a comment here. So thank you so much for doing this. This is really important. Cerebellar hemorrhage, in children is very different than it is in adults, right? And so in adults, the most common cause of cerebellar hemorrhage is spontaneous secondary to uncontrolled hypertension. That's by far and away the most common cause of spontaneous atraumatic cerebellar hemorrhage in adults. In children, that's almost never the case. In children, cerebellar hemorrhage is almost always, that's atraumatic. Spontaneous is almost always an AVM until proven otherwise. It can certainly be completely different animal than surgery for cerebellar hematoma in adults. And I do wonder if that consensus guideline, because it's worded identically to the adult guideline, was taken from the adult guideline just because intuitively the posterior fossa is a small space by volume. There's direct brainstem compression and hydrocephalus. Why wouldn't you take out a hematoma back there? But there are a couple factors in our mind that will influence us wanting to take a child, particularly in the evening hours. One is if you have an AVM and you don't understand the architecture of it, you can get into a lot of trouble very, very quickly due to profuse hemorrhage, brain swelling, incomplete understanding or control of the feeding vessels, or if there are deep veins that are actually main draining veins and you don't know that going in, you can get into some trouble if you accidentally take them while you're trying to take out the AVM without completely disconnecting the feeders. So that was like the first thing. And then the second thing is that unique to kids with posterior fossa brain compression, having them lay prone for prolonged periods of time can sometimes be very challenging. There was a very recent case, I think, Dave, it was yours, with a kid who had neurogenic pulmonary edema and would never have been able to tolerate prone surgery. It probably would have led to a cardiac arrest. And from our standpoint as surgeons, cardiac arrest in the prone position is impossible. Like you have to quickly whip stitch the kid closed just so you can flip the kid over to do chest compressions. It's a nightmare. So just to give you guys some very practical considerations, that when you read that guideline and you kind of wonder why we're not taking every kid in the middle of the night with a 3-centimeter hematoma, even though I think that that's a consensus guideline, I'm a little curious about it just because pediatrics is so different than adult.
Thank you. Thank you, Dr. Hoffman. Yeah, that was a very good comment. And even though it is in the guideline, I hope I meant to keep saying, and I hope I did. I'm just so nervous. I don't know if I did, but I hope I was saying it still depends on the surgeon's opinion and the surgeon's clinical judgment. It's very true. It's different in kids, and we can cause a lot of trouble, especially going in, especially child that is not hemodynamically stable. And that's what exactly we had last time. I think it was 2 weeks ago now, where it was a child that had significant respiratory issues, and it just was not safe to go to operate immediately. But yeah, sorry, I totally meant to keep saying that despite the consensus, it is the surgeon's judgment.
Oh yeah, no, Janette, don't interpret it as interpret it as a criticism. It's not. I wanted to give some background as to why we do what we do. No, thank you. This is super important. You're doing a fantastic job. Keep going.
And again, this is a consensus guideline. This does not substitute clinical judgment in any way, and it does not substitute there's that kind of the discussion between the specialties, that the multidisciplinary approach, that's the most important, and what we decide as a group. Even though there is a guideline, it doesn't mean that this cannot be changed based on the child's status and the kind of a clinical opinion at the time. It's kind of, it helps to guide it, but definitely the clinical judgment, as in any other case, it's extremely important. So what one of the questions always comes up, whether it is the cardiac hit that bleed, and those even more so, or any child that has a bleed in the brain, what are the optimal blood pressure targets? We don't have them. There was no consensus. So it's kind of the consensus there, not the consensus, but what was kind of put into the guidelines is exactly what was put into the ischemic stroke guideline in 2019. And it's kind of to keep the normal tension, prevent hypotension because we don't want to create ischemic injury, but somehow somewhere around 95th percent is probably appropriate. Again, very much depends on the situation, how the child is acutely doing, and there are no really good thresholds. So it's a very fine balance between trying to prevent rebleeding, which is extremely important, but balancing that adequate perfusion so we minimize the risk of ischemia. So this is something where there is no consensus. It kind of goes patient to patient. Whether the prophylactic anti-seizure medication should be given, but again, there was no consensus. My experience is most of the time it is given, and every time I was involved with these kids, we did start prophylactic anti-seizure medication, but there was no consensus reached. Most experts will suggest to wait until there is electrographic clinical seizures. I feel that most of us in a clinical practice will simply start anti-seizure medication, especially as something like levetiracetam, or now even more commonly lacosamide, just because they have very low side effect profile, and I think preventing seizure is extremely important. Some advocate to do prophylaxis, especially high-risk cases. What are high-risk cases? Significant cord bleed, large hemorrhages. As I said, even the consensus was not reached. I feel most neurologists and most kind of neurologists in ICU will recommend the prophylaxis. EEG is very important to start the EEG. Any child with decreased level of consciousness, critically ill child should have continuous EEG done if possible. Again, depends on the center. Some centers simply don't have that possibility. What about the prophylaxis of the VTE? That's again controversial. It's considered safe and can be started, is not always done. Especially there was no consensus around chemical prophylaxis. So using heparin or low molecular weight heparin, there is always that risk, especially with the larger bleed, and starting early on the prophylaxis will cause rebleeding, will cause further hemorrhage. So the risk is there. So it's not really clear. There is no consensus on who is the ideal candidate when to start it. Most commonly, if the prophylaxis is started, typically not earlier than 24 hours after the initial presentation, after the initial bleed. And even then, very carefully, and there has to be a good reason, and the child has to be carefully watched. Sometimes we wait a couple of days. What about the blood transfusion threshold? Again, there's really a lack of evidence, and part of the lack of evidence, this is rare, even though we see them as kind of a neurologist in the hospital, it is still fairly rare. There is not enough evidence. Lots of evidence that is published, retrospective studies, small studies from single centers. And there is so much institutional variation. So there is really no good consensus. There is not even a good consensus on platelet transfusion. Again, lots of variation, kind of depends. What we do right now depends on a child, depends on how child is doing, depends what is the underlying etiology. It's just case by case. Decompressive craniotomy. So, and this is, I think, what Dr. Hoffman was also alluding to, and is a very, very important. Yes, there is established role. However, sometimes the child is just not it's just not safe to do that in that hyper acute timing. And yeah, as Dr. Hoffman said, there was a case 2 weeks ago where it just simply wasn't safe to do it right away. So there was no consensus when to do it in pediatrics. And the morbidity is actually very high despite the decompressive craniotomy. Large cerebellar bleed, pushing on posterior fossa structures and displacing brainstem is still associated with very high morbidity, although it does decrease mortality. again, if we do it too early, it might actually worsen the outcome even acutely. But even a long-term outcome, it can still be associated with significant morbidity. So there is no good timing. There is no consensus. So these are the areas where we'll need more evidence. We need specific trials. And because of this, we started a hemorrhagic registry. So the International Pediatric Stroke Organization is the ischemic stroke registry has been in place since about 2003. And since 2019, there is a hemorrhagic stroke registry. Just try to get a better idea how these kids are doing, what is done acutely, just to guide these kind of advice and guidelines. So again, so where was the consensus low? Optimal blood pressure targets, which intensivists will tell you that's the most important question they have, and they would like an answer. Unfortunately, we don't have it yet. It's case by case. As I said, seizure prophylaxis. Interestingly, I thought the consensus would be there, but it wasn't. And the consensus levels was low. I don't know. I personally would feel uncomfortable not to start for at least 7 days. Timing of the prophylaxis. For VTE, it's again was low, which kind of makes sense because it really depends on the type of the bleed, the etiology of the bleed, how big it is, and if another surgery is, for example, expected, then we would avoid some of the blood thinners. What are the transfusion threshold? That was a low consensus as well. It's very institution dependent, again, very child dependent. Now, the craniotomy, especially supratentorial, the consensus was again low. It's case by case decision because it very much depends on the patient, the stability of the patient, and also will it really improve the outcome and improve morbidity and mortality. So once these children get out of that acute phase, it will be very important to support them to optimize the long-term outcome. And the same as we see in ischemic stroke, we talk about what's called kids grow into their deficits, which means that especially in younger kids, we don't really know what deficit they have until they are at the age level when we expect the certain skills to emerge. So very often we cannot really tell the full extent of their disabilities. Neurocognitive deficit, as I said, so will become apparent as the child gets to the level and developmental level when we expect it. So in the acute phase, especially in the acute phase, sometimes the child looks fairly well. The deficits, especially younger child, the deficits might not be apparent and everything looks good until they get to the school age, and then the learning problems, attention problems emerge. In adolescent, what we often see is difficulties with kind of the social interaction, that little higher level functioning. Impulse control is very important. It's very often impaired as well, which interferes with the normal functioning with peers at home and in school. So one of the areas that are, if possible, it's important to have that long-term neurocognitive follow-up and repeated testing, which might be complicated, especially if this needs an insurance, and it can be the area that it's kind of difficult to follow up on those neurocognitive areas and the neurocognitive outcome support. That's and it's just it goes across. It's kind of across the world. It's anywhere. It's in developing countries, in developed countries. This is the problem, that kind of have access to that long-term neurocognitive follow-up. Motor recovery. So most of these kids will have motor issues. That's kind of a given for most of them. And physical therapy, there is way more. It's way better described than the plan for physical therapy is there for the kids. It's just easier to plan for the motor therapy, management of the tone, management of the gross motor function, mobility is much easier. When it comes to communication skills and more defined motor skills, that adaptive learning, that becomes much more difficult and needs kind of a longitudinal follow-up. Cognitive rehabilitation, we've been talking about that for years. It's still not clear how to support what it actually even is cognitive rehabilitation and how to support it. And that's even for children with ischemic stroke, which is way more homogeneous and way better described and way better studied in terms of long-term support. So even less so we know about hemorrhagic stroke. And one of the things that do come up, especially with these children with the posterior fossa AVM, and as I said, they're not rare. We have couple a year, which to me is not rare given the significant morbidity. And it very often, in terms of long-term outcome, it's even hard to tell for us if the children will wake up. Many of them are significantly impaired in terms of their alertness early on if they have big posterior fossa bleed. And there's always that question, will they wake up? How they will wake up? What they will be doing when they're waking up? And it might take weeks, even months for them to get that alertness. And we still won't be able to tell what their cognitive skills will be, especially if they're significantly impaired motor-wise and they're almost or pretty much locked in. It's very, very difficult to tell how much cognitive skill they have. So that becomes really tricky. And it's pretty much impossible to tell early on, so only time will tell. So plan to school, it's very important to have the plan for school, working with school, the support for the schooling, that's very important. And lots of schools have those abilities to work with the families. In terms of epilepsy, what is the risk? Anywhere between 10 to 30%, depends on the location, cortical location, larger bleeds, of course, there's a higher risk. Typically we don't keep those children when they leave hospital on anti-seizure medication unless they were actively seizing, and they just need a follow-up because the seizures can come months, even years later. Psychosocial support for the family is extremely important because it was shown that the children that have strong psychosocial support and strong family support tend to do better. Very often such a significant disease and significant disability in a child comes with emotional distress in the family, financial burden, especially if one parent has to stay at home and look after the child. So very often the family dynamics is different and it's a lot of stress. Siblings needs, there was one of the things that were identified in the literature. The siblings needs are very, very important because sometimes the siblings might just not get enough support and attention in terms of their own needs that are not perhaps as obvious, but they're still there. Those are still children. So support resources, so access to social work, psychology, very, very important. And especially the older ones, as they get older, transition to adulthood is very important. So how do we prognosticate? Because it's always a question, and I know I'm almost out of time. I'll finish in 2 minutes. The predictors of outcome are extremely important, and that's what every parent wants to know what my child is going to be. And sometimes we just don't know. Again, motor-wise, we usually can predict. Looking at the imaging, we can predict the motor disability. The cognitive disability is extremely difficult to predict, and that it becomes very, very difficult. Again, the sicker the child, the bigger the bleed, the longer need for intubation, sedation, evacuation of the hemorrhage. Like all those, of course, will make more the abnormal outcome more likely. However, it's very, very difficult. Again, if there is a big hemorrhage, more likely there will be negative in the impact, the outcome will be there'll be more likely adverse outcome. So what did I want to say today? And hopefully what I communicated was kind of talk about what the consensus what kind of consensus were and what is still controversial. Again, even though, as I said before, if the consensus is there, the clinical judgment discussion with our colleagues and working together, that's what at the end will actually improve the outcome, hopefully. And there are some areas that are controversial and it's very much case to case, and again, discussion between the providers. So I think we have here very nice and collegial environment here, which I feel it's been extremely helpful with all our very difficult cases. I feel that the way how we communicate about these cases, I feel that we've done as well as we possibly could have with these with these very sad and very complicated cases. So the most important, again, one of the most important thing that was strongly advised was to have some sort of evidence-based protocol, just the management, just to have the plan how to assess these children, how to get them into kind of the proper setup where their basic like hemodynamics and the monitoring will be done as soon as possible. And again, long-term neurocognitive follow-up is extremely important, and it's not easy. Many centers do have difficulties with kind of access to the psychologists and kind of and as I said, neurocognitive rehabilitation. Although we talk about this a lot, it's just hard to tell what exactly does it mean, and it's very much child to child dependent. Thank you. Yes. I'm happy to answer any question. Okay, Kara? Oh, I thought it was a question.
I don't have any questions. There was one question in the chat, though,
Yeah.
about concerns with starting anti-seizure medicine sooner than later. I know you did mention it's not in the consensus, but can you talk about timing?
Yeah, the timing. So you again, like there was no really good consensus. Like as what I've seen, it would be when all the cases I've been involved, we simply we start medication soon. We just simply, as soon as there is a child with significant bleed, especially the child that cannot be clinically well assessed because they have altered alertness, we know that this child will be clinically close to impossible to assess. I always suggest, sorry, not usually, I always suggest to start anti-seizure medication. Even though EEG monitoring is started, I still suggest for those 5 to 7 days. And again, I practice including training in 3 centers, and we always started early. And as I said, something like levetiracetam and now more and more lacosamide, we never had any adverse reaction that would prevent us from simply doing that.
Though, Janette, it's interesting. From the neurosurgical standpoint, the literature to start anti-seizure prophylaxis in traumatic brain injury is strong and longstanding. However, the literature for pediatric traumatic brain injury specifically, it speaks to it not doing it. And the only large series that have ever been published suggests that the risk of having a seizure is actually lower than the risk of having an adverse event from the anti-seizure medicine. And I refer to some of the early series that were done out of LA County, actually, is where that data came from. So that's why we have not always traditionally started anti-seizure medicine in pediatric patients, even though the literature in adult patients suggests otherwise.
And that's absolutely true. And also some of the older medication like phenytoin and phenobarbital, and phenobarbital is also more sedating. So I think that was more kind of that caution. Now with the neuromedication as levetiracetam, it's just a little bit easier to start that. And again, there is no consensus. So not starting and watching child clinically is absolutely appropriate. And especially the child that is easily examinable is absolutely appropriate. Those that have bigger bleed, harder to examine, I think it's not inappropriate to start it as well. But the consensus is not there, so not starting is not wrong.
Hey, Janette, thank you. Really very nice presentation. Just reflecting on acute stroke, I think there's probably nothing that demonstrates access to care and health inequities like dealing with pediatric acute stroke. And obviously, it would be a lot different if a child rolls into Phoenix Children's Hospital ED with, acute hemiparesis than if they roll into Lake Havasu with the same presentation. What do you see as the management for remote acute stroke management? I mean, I think the adults have this dialed in pretty well with telestroke. I'm not sure that it exists really anywhere to a meaningful extent in pediatrics. Do you think that's something that we could offer in Arizona?
So it was a very good question. So for ischemic stroke, there are some options for essentially doing remotely and just guiding. The question in the pediatric stroke will be, does the remote center have the imaging availability, especially the vascular imaging, to even know what's going on? So that would make it very difficult. Right now, essentially the consensus is that these children should be as soon as possible in terms of their stability and the availability of just the transport. These children should be actually managed in the tertiary center, in the centers with the appropriate expertise. If that's not possible, I mean, the child with the hemorrhagic stroke, that if the center has availability of the vascular imaging, that's probably a little easier, but to at least knowing what's going on. Without vascular imaging, you wouldn't really even know what's going on. Like it is something surgically potentially that needs to be surgically managed. It is coagulopathy, so that would make a management a little bit difficult without access to vascular imaging. If the vascular imaging is available, then it makes it a little bit easier. Although the child that needs a neurosurgeon probably needs to come to the place where the neurosurgery is, especially if the posterior fossa bleed, and the question of decompression is even there. So this is a little trickier. The hemorrhagic would be trickier. The ischemic stroke, I can see some ways of doing that, especially if there is the imaging is there and we can have a clot identified, because right now, according to International Pediatric Stroke Organization, for ischemic stroke, the indication for TPA it would be to actually have a clot identified. So there has to be that access to vascular imaging. And honestly, what we do for acute stroke in children, it's in ischemic stroke is actually very similar to adults. So that would be possible, and as long as the provider is actually comfortable doing that. But in the hemorrhagic stroke, I feel that's a little bit tricky to manage in a place without a neurosurgeon. I hope it answered the question.
Sure. Yeah, I was thinking more. I mean, obviously, if somebody needs evacuation, they're going to need to get to a major medical center. But time is brain, and the seconds are ticking away. And for an ischemic stroke, I mean, I think every emergency room in America, for the most part, has a CAT scan and a TPA for treating adult strokes. And so, there could be opportunity to manage,
Totally.
a bad situation in a child rather than a 2 or 3 hour transport time by
Absolutely.
plane or even longer by ground.
Yeah, for ischemic stroke, I can definitely see that. But it would be, and especially in an older child, that it's easier after doing the CT scan. It's easier to examine, and there definitely focal deficit. Ischemic stroke would be much easier. And as I said, our TPA guidelines are actually very similar to adults, so that wouldn't be difficult. Hemorrhagic is a little trickier. But I actually had a phone call from I think from Tucson a couple months ago, and there was a child with a bleed, but there was a strong suspicion the bleed is from the treatment. The child had leukemia, so I felt like there was no reason to transport the child, and we actually managed it with the PICU there. So you're right, in some situation, especially if they have a pediatric ICU, I think these can be managed.
Thank you.
Thank you.